Ladies and gentlemen, thank you for joining the Lake Superior Quality Innovation Network. Is your mouth really part of your body? Making the Diabetes and Oral Health Connection. Your host for today, Mark Walsh. With again.
Thank you, Christina. Hey everyone, this is Mark Walsh from MUCOSAL, which is part of the Lake Superior Quality Innovation Network. And welcome today to our Ambulatory Path Learning and Action Network event featuring Susan Deming from the Michigan Department of Health and Human Services. Susan is going to be talking today about oral health and the connection between that and diabetes. Before I introduce Susan, she has graciously allowed her slides to be shared. Anybody that's interested in that can email me at loush@mco.org. My email address is in the chat box. And also, if you have any questions, would you please you can save them to the end and you can ask Susan directly. We will open it up for questions and answers. Or you can write them in the chat box and I can read them to Susan. And finally, at the end, we're going to put up an evaluation, and I really wish you take a couple of minutes and do the evaluation. It really does help us guide our future events, and we really appreciate your feedback. So, without further ado, I'd like to introduce Susan Deming. She is the Early Childhood Oral Health Coordinator, and she also is the Health Systems Integration Coordinator at the Michigan Department of Health and Human Services Oral Health Program based in Lansing, Michigan. We're very happy to have her here today. And Susan, the floor is yours.
Okay, thank you, and thanks for those that are listening in this afternoon. I'm sitting here looking over downtown Lansing, which is beautiful outside, but I understand it's extremely cold out there, so I'm happy to be in a nice warm conference room here talking to you guys. I am actually a registered dental assistant, a registered dental hygienist with a bachelor in health studies with the Michigan Department of Health and Human Services. And the oral health unit actually sits within the cancer section here at the Michigan Department of Health and Human Services because nobody else really knew where to put us. So we really need to be our own section, but we don't have enough people yet for that. So we're working on that. But how many of you really think your mouth is connected to the rest of your body? Well, of course you do. But for many years, dental and medical health have been separated, and still, in many respects, are. But we're seeing more and more integration of the two, and I'm here today to discuss those connections we can make with people with diabetes and their oral health. Let me see if I can make my slides go. So today we have a few learning objectives I hope you go away with after our presentation today. We will discuss some oral symptoms people living with diabetes may be experiencing. We'll also talk about how you can help people with diabetes manage their oral health and thus hopefully improve their management of their diabetes. And lastly, I'm going to try to give you some available resources and websites that can help you help people that you work with improve their diabetes and thus improve their overall health. The detrimental effects of diabetes on oral health have been well documented. People with diabetes have a marked increase in the risk for periodontal disease or gum disease and experience almost 3 times more periodontal pathology than their non-diabetic counterparts. Additionally, tooth loss is up to 2 times more frequent in people with diabetes than people who do not have it. Diabetes and oral health are 2 of the leading health indicators in the United States, and diabetes can cause changes in the teeth and gums, especially when poorly controlled, which we'll talk about in a little more detail later. Conversely, having poor oral health can lead to further complications of diabetes. So basically, people with diabetes are at a greater risk of losing teeth, have a harder time controlling their blood sugar, especially if they have poor oral health. So last year, the Oral Health Program collaborated with our diabetes section here at MDHHS and our epidemiological section to develop the Michigan Department of Health and Human Services Oral Health and Diabetes fact sheet. And from this fact sheet, we're going to pull some information, or you can actually find some information that has an impact for people with diabetes. So first off, we put in here, what exactly do we mean by oral health? It's more than just about teeth. It says state of being free from chronic mouth and facial pain, oral and throat cancer, oral pores, birth defects, tooth decay, loss of teeth, and other diseases and disorders that affect the oral cavity. We know that an estimated about 32% of people in Michigan do not visit the dentist at all, with 16% of those have 6 or more teeth missing due to oral diseases such as tooth decay and gum disease. As for our youngish adults, at least young to me, about 35% have lost at least one tooth due to oral disease, and for older adults, at least 10% have lost all of their teeth, which is still better than what it used to be like back in the 40s and 50s when it was more than 60%. So if you think about it, eating, talking, and socializing with others gets more difficult the more teeth you are missing. And another page that we have on the fact sheet on the reverse side is some tips that shares about controlling oral health and diabetes, and then some other known facts that we know specific to Michigan. Somewhere there it is. Come in. I gotta have it right on that little arrow. So more adults with diabetes, about almost 70%, visited the dentist in the past year compared to adults with diabetes. So it's better than, again, it used to be in years past about visiting the dentist. And dental insurance has really helped with that. Then we have adults with diabetes have a higher percentage of tooth loss, 6 or more teeth, compared to persons without diabetes, regardless of their age. And adults with diabetes also had, sorry about that, not done. Different in tooth loss by race. So blacks had about 48.5% compared to whites, and then it had something to do with their smoking status too. So if they were a current smoker, they had more tooth loss than those compared to those who have not smoked. And this next slide really kind of shows the prevalence of those missing 6 or more teeth of those people with diabetes compared to those people who did not. So it kind of gives you a big picture. Naturally, there's more teeth loss the older you get, of course, but people with diabetes just seem to have more of an issue with that. So in Michigan, we have, or not just specifically Michigan, but nationally we have an ADA as well, the American Dental Association, which conversely goes with the other ADA, the American Diabetes Association. So I'll be referencing both of these agencies for resources for you, but I'll try to differentiate them as I go. So according to the American Dental Association, some of the most common oral health problems associated with diabetes are, of course, tooth decay, the tooth caries cavities, gum disease or periodontal disease, delayed healing and infections in the oral cavity, salivary gland dysfunctions, which lead to xerostomia, which is dry mouth. They have more mucosal or tissue problems, and they have more taste impairments and tongue issues. And we're going to talk about each one of these, and I have some pictures to show you on there too. So we're going to take a look at periodontal disease, gingivitis, periodontal disease, tooth decay, and candiditis. I knew I'd screw that one up. So the candida bacteria that can be in there fresh. This is a really big slide, so please forgive me on that. But I took this from the American Diabetes Association, but it tells an important story about how important oral health and the diabetes connection really is, and all the different avenues having poor glycemic control and or poor oral health can affect the person's health. So, there can be immune dysfunctions that actually lead to periodontal disease or gum disease, can lead to oral cancers. And then there's other side effects, maybe from the drugs that people take for diabetes that impact their salivary gland issues and can lead to more tooth decay or dental caries. So let's talk a little bit about tooth decay. I hope this doesn't gross too many of you out. It's a common oral health problem for those with diabetes. When diabetes is not controlled properly, the high glucose levels in the saliva may help the bacteria thrive that promote dental decay. Diet is one of the biggest contributing factors in dental decay, which may be the biggest relationship with people with diabetes and tooth decay as well, because a lot of that is interrelated with their diet and what they actually put inside their bodies. Because diabetes reduces the body's resistance to infection, minor areas of tooth decay can become major issues. And also there may be an increase in salivary dysfunction. So a dry mouth leads more to tooth decay. Simply because you don't have those buffering agents in your saliva to help with that. Some people with diabetes have a greater incidence of gingivitis, which is the first stage of gum disease or periodontal disease. And research suggests that people with diabetes are at a higher risk for this. And it's usually characterized by inflammation and bleeding of the gum tissue, where this is an early stage where periodontitis or periodontal is more advanced stage. So people with diabetes are at a greater risk because they're generally more susceptible to bacterial infection, and this is caused by certain bacteria in the mouth. And they have a decreased ability to fight bacteria that does invade the gum. So with gingivitis, the gum tissue can be redder, it can bleed easier, but there hasn't really at this point been any bone loss yet. So gingivitis is completely reversible, so if this person really steps up their home care and tries to get all the bacteria out of there, this can be reversed. Having the person with diabetes visit the dentist a little more often can help with that as well. So let's talk a little bit more about periodontal disease. Whoops. I'm missing a picture here for some reason. I don't know why. But if the blood glucose levels are poorly controlled, the person is more likely to develop serious gum disease and lose more teeth than people without diabetes. And like all infections, serious gum disease may be a factor in causing blood sugar to rise and may make diabetes harder to control. Periodontitis is initiated by a specific bacteria that activates a series of inflammatory and immunological changes leading to the destruction of connective tissue and bone. So this is a much more serious oral disease than just specific gingivitis. Some of the signs of periodontitis, gums may be red and puffy and bleed easy, as with gingivitis, or they may not. Sometimes smoking or tobacco use can mask the health of the surrounding tissue, so the tissues look fine, but underneath they are breaking down, and the bone is deteriorating. So these people may have bad breath, or talk about having a bad taste in their mouth. The gums start to pull away from the teeth, which is called recession. And in the advanced stages of periodontal, the person can lose as much as 50% or more of the bone around the teeth, and yet still be able to maintain those teeth in the oral cavity. If we catch this disease soon enough, we can maintain it if there's frequent dental visits and the person does a really good job with their home care. So people with periodontal disease need to be monitored closely by the dental team. And some insurances will cover routine maintenance visits for these people, like dental cleanings, for people with diabetes or gum disease more often than the regular 6-month visit. So we would need to check with their insurance company if they have diabetes to see if they can go every 3 or 4 months to get their teeth cleaned, which would really aid in helping them control their disease. Research suggests that an infectious process with a prominent inflammatory component, it can adversely affect the metabolic control of diabetes. And so conversely, the treatment of periodontal disease and the reduction of that oral inflammation may have a positive effect as well. So there can be some salivary gland dysfunction with people with diabetes. Because of the immune factors are negatively affected by diabetes, these patients are at an increased risk for lesions and other disorders. This has been supported by recent studies showing that oral soft tissue disease occurs up to 10 times more frequently in patients with diabetes than in those without. So salivary gland changes. One would be enlargement of the glands. They include non-neoplastic enlargement of the parotid salivary glands, decreased saliva flow rates, and changes in the saliva composition. So they could have maybe thinner saliva or more ropey, viscous saliva, which could promote more dental caries or promote more gum disease. Bilateral enlargement of these parotid glands has been reported to occur in 10 to 48% of persons with diabetes and may be more common, particularly patients that don't control their diabetes as well. Xerostonia, or the dry mouth, as we talked about before, can occur in 40 to 80% of people with diabetes and is related to the decreased salivary flow. This could also be a cause of increased decay. As with other oral health conditions, the symptoms are more pronounced, certainly with those with diabetes. There also can be some mucosal disorders or tissue disorders that happen with people with diabetes, such as lichen planus, lichenoid mucositis, atrophy of the tissue, and candidiasis or thrush. These disorders are related to the lack of salivary flow, for one thing, and the generalized immune dysfunction seen in people with diabetes. So the first one you see, the top picture, is lichen planus, and it could mean, lichen planus has kind of a broad definition, sometimes for things in the mouth that they can't really explain, but it presents an ongoing chronic inflammatory condition that affects the mucous membrane, so usually along the cheek or maybe along that soft gingival area around the teeth. It may appear as white lacy patches or red swollen tissue or open sores, so it has different appearances, but this is the most common one, that white lacy one, and these lesions may cause burning pain or other discomfort, such as in that top picture. Then the lichenoid mucositis looks similar sometimes to the lichen planus. It's also an inflammatory condition. Sometimes they can't tell it apart from lichen planus, and it's often difficult to diagnose. And then they can have atrophy of the tissue area, so which means that sometimes they'll get some sloughing. It becomes dry or red, and the tissue kind of looks like it's peeling off. I worked in a periodontal office for 25 years, and I saw a lot of this, but I didn't at the time relate it to people with diabetes, but I certainly would do that now. Similarly, these changes can be called lichenoid drug reactions, and they can occur as an adverse side effect to medication that people are on as well. And then we have the thrush or the candidiasis, like on that bottom picture. This may be the result of increased salivary glucose levels, which promotes the overgrowth of that candida bacteria, as well as decreased antifungal immunoglobulins in blood, which may be caused by the diabetes. There also can be tongue and taste impairments. After gum tissues, the oral site most frequently affected is the mucosa of the tongue. In a study of 176 patients with diabetes, atrophy of the tongue was found in about 27% of the patients. Normally, the dorsal surface, which is the top part of the tongue, has an even distribution of those little filiform and fungiform papilla, those little bumps on your tongue, giving a textured appearance that is light pink in color. What happens with people with diabetes is they get more of a fissuring of the tongue, which may be the result of, again, low salivary flow, which alters the environment of that whole oral cavity, slow healing, and easily traumatized in patients with diabetes. So again, over their tongue may appear kind of bald-looking, where it's kind of flat-looking, doesn't have any fissures at all. And again, they can get thrush on their tongue as well as the other tissues. And then there's something called geographic tongue, which is kind of like what's in the bottom picture. It's It's another condition of the tongue that's more common in people with diabetes than in non-diabetic patients. It can be called benign migratory glottitis. It features like a focal atrophy of the papilla again. The papilla looks funny on the tongue, and it can present itself as really irregularities on the tongue with these white borders around. It almost looks like a map on the tongue, and it changes over time. So the next day it might look different too, and that's why they call it geographic tongue. Taste is also impacted by this. Any condition that affects the tongue normally affects the taste because that's where your taste buds are. So patients with diabetes appear to be especially prone to taste disorders. And type 1 diabetes was found to be associated with a significant and specific impairment in glucose taste detection. And this decreased taste sensitivity to glucose may result in an increased preference for glucose because more of the sugar would have to be injected in order to produce the same taste sensations, and this situation may complicate management of oral issues in diabetes. I often found this when I worked at the periodontal office with the older patients. They just couldn't taste things anymore, so they continually wanted to suck on candies or peppermint candies or things that they could actually taste. And that's a real problem with the elderly and people with diabetes, is that they just don't taste that glucose anymore, so they do want to do that, suck on sugar candy. Angular colitis is what's like in that top picture on the corners of the mouth. And that's a fungal infection commonly seen right at the corners where it feels like there's small cuts on the side of the mouth. Sometimes it has to do with saliva as well, but it's very painful. I did want to talk about screening for diabetes, and particularly in dental offices. I was telling you about the integration that we're seeing here at the state level and at public health, trying to get the dental folks on board with asking patients about diabetes and trying to determine their A1C right in the dental chair. It is screening for diabetes is part of the 2020 FDAC. It's not particularly through the dental offices, but it is on their radar. There are quite a few studies now out where they are screening for diabetes in the dental office, and I'll tell you what we've been doing here in Michigan in just a second. But this does really help if we can get the dental providers to refer to medical providers if they suspect someone has diabetes. And it's also a unique setting for screening patients that use tobacco use and their relationship to diabetes. So there's nothing more oral than that. Tobacco really affects the oral cavity. It's the number one risk factor for gum disease and other things in the oral cavity, oral cancers. So we do look for that, and to relate that to diabetes is important. And then certainly can use the dental providers for more further education on diabetes and pre-diabetes, and just trying to get them connected to some medical care. So in Michigan last year, we did a major survey or an assessment of as many oral health providers we could in the state of Michigan. We worked with Delta Dental, who funded a project for us to send out these questions asking what kind of knowledge they had about screening for hypertension and diabetes, what they did in regards to that, and we came up with some pretty interesting results, which I'll share with you. Some of the questions we asked, we did some demographic questions. So we asked if they were a dentist, a dental hygienist, or dental assistant. We asked what kind of setting they practiced in, whether they were in a general dental practice, a specialty practice, if they worked in a community clinic, or if they worked for academia, those kind of things. We followed their zip codes, how many years they practiced, and then we asked on which patients do you take blood pressure readings? You know, do you do it on everybody? Do you just do it on people 18 years and older, people with just a history? And then we asked them to rate their comfort level on taking blood pressures. And if you look at the chart in the slide, you'll notice that they're very comfortable. Most of them are very comfortable taking blood pressures because it's standard of care. They're supposed to be doing that. So when you go to the dental office, you should be requesting they take your blood pressure. They should be doing that on all patients for every visit that you have. And so we asked them if they did not, why not? And we asked them if they knew what the normal blood pressure reading was. So that was interesting. And then we asked the patients, do you screen for diabetes? And we asked the same questions. Do you do that on all adults? Do you do it on everybody? Do you on patients with a history? And then we asked their comfort level as well. And you can see from the slide that they're not quite as comfortable checking for diabetes as they are for blood pressure. So we're going to be working on that. And we asked them how they screened for diabetes. Did they just do a questionnaire, a question on their health questionnaire? Did they do a point-of-care finger stick? Did they do a hemoglobin test? How did they do that? And did they know what kind of oral signs that they need to be looking for, those kind of things. So that was kind of interesting. And from that, we have some recommendations and some next steps came out from our advisory committee. So right now we are working on developing for the state of Michigan certain guidelines that will help oral health professionals when they're doing screenings for hypertension at your site and how to do this with diabetes as well. So what kind of things that they could do to check for that, what's recommended that they do, and help them learn how to refer. And we also will, after that, try to develop some educational materials that they can use right at your site for that as well. So we're hoping that that's a good thing and that we see more referrals for diabetes from the dental office. So when that comes out, I will let you all know. And so hopefully, we're looking probably will take another 6 months before that's available. So how do we really manage the oral cavity when a person has diabetes? Well, we do want to get them to the dentist a little more often. Normally, unless that person's doing a really, really good job at home, maybe more frequent cleanings would be helpful for them. And again, like I said, you could check with their insurance to see if they're covered. I know I have Delta Dental, and they do cover mine, not because they have diabetes, but because I have end of gum disease. They'll cover more than 2 cleanings a year, so that's really helpful for people. We talked about that. And then we check their medical history. And through the dental office, we're trying to educate dental providers that they need to be asking certain questions to see if a person's more prone to diabetes than others. And some of those questions can be certainly asked on their standard medical history. And then education on their connections, of course. That's something you guys can help with maybe. Just trying to assess on there. Teaching them proper ways to brush their teeth. Encourage flossing daily. I know the national news had this report come out that they don't have any real good evidence that flossing does any good, but that's a bunch of hoo-ha breaks it down to people. So I can tell you we know that flossing does do some good, so if people floss every day, that's better, for sure. And then talking to them about trying to, reduce their tobacco use or stop tobacco use will be good. The whole referring to a medical provider if an oral health person is doing an assessment and feels there's a risk for diabetes is a good thing. And just trying to get them connected to the dental or the medical providers is good. And you can, we teach dental providers to also talk about goal setting for their people with diabetes. So what can you do? And if I understand this right, a lot of people in the audience work with people directly that have diabetes. So you can maybe share some of your new knowledge on some of the connections of oral health, diabetes. If you need some help on how to teach them how to brush their teeth or use flossing techniques, there's a lot of resources I can help you with on that. Have diabetes and oral health information materials available. There's a lot of things out there that I will share some of that with you in a little bit. And just trying to coordinate the primary care dental providers and the management of care. try to encourage the primary care provider to talk to the dentist and the dentist to talk to the primary care provider regarding that patient. You can ask patients if they have any concerns with stuff going on in their mouth. That may be the first thing or the one thing that you could do to try to encourage them to get some help if they're having trouble with something in their oral cavity. And then, like I said, routine visits to the dentist they're saying at least one time a year. I am recommending probably more often than that for people that have diabetes. Encourage self-management education, ongoing support, for sure. We are trying to work with our diabetes self-management programs here at the state level and making sure that they have an oral health component so that when patients are taking this kind of training that they are subjected to some of that information. So they got that. Making collaborations here at the state level, I do a lot of that with my health systems integration role here as I try to talk to everybody else that works with the Michigan Department of Health and Human Services and try to promote oral health into their work plans and their education efforts. We do have a Michigan Oral Health Coalition if you're interested in learning more. They also are really trying to work with the integration piece on connecting dental and medical services. DPAC, the Diabetes Partners in Action Coalition, if you're not aware of that, is a really great coalition to sign up and be a part of. We actually, several years ago, developed this diabetes and oral health fact sheet for them. So that is still available, still fairly current. And then again, I work closely with the diabetes section here. I'm actually moving April 4th onto their floor. So I'll be right next to them physically too, which will be a bonus. And then to work with the tobacco-free coalitions or the tobacco center at the department has also been really helpful for me to try to promote the oral health diabetes connection as well. And some of the resources that are out there, which some of the websites that you can go to, certainly I'm sure you know about the National Diabetes Educator Program site. The ADA, this would be the American Dental Association, has a lot of information regarding diabetes on their site as well. So that can be helpful. The National Institute of Dental Craniofacial Research offers these dental tip fact sheets that you can download right from their site, and they have one specifically for diabetes. The IDF put out something a few years ago on oral health for people with diabetes, which is, we're going to be utilizing this when we develop the guidelines for Michigan. But this is a good document to refer to as well, and then of course DPAC is good. And then if you want a copy of the Oral Health and Diabetes in Michigan fact sheet that we updated last November, let me know. You can just write me an email and I will send that off. Again, I'm sorry I kind of went on that, but I can open it up for any questions.
Thank you so much, Susan. And definitely, Christina, if you could open up or let the participants know how they can ask questions. And if the WebEx operator could please put up the evaluation questions for those of you that are contemplating questions or listening to the questions being asked. If we have any, they can fill out the evaluation. Thank you.
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. And Mark and Susan are waiting for callers to join the queue at this present time.
Thank you very much, Christina. I don't have anything from the chat. If you don't have any, Susan, I do have one or two that I'd like to ask.
And we don't have it any on the line, so go ahead, please.
Okay, great. Before I do that, if you guys could listen to the following questions coming up, if you could take just a minute or two to take the time to solve the polling questions at the end of our evaluation is really awesome. So what are some of the questions that are asked for diabetes screening in a dentist office? What would be the questions that would be asked?
So I think they would first ask if they've been diagnosed before.
Okay.
And then they should ask about their diet, would be something, or if they're having pain in their mouth, those kind of things. But we're going to be promoting that they actually do a finger stick, which we'll get a lot of negative comments on because they're not reimbursed for that. So a lot of this has to do with how they can be reimbursed. So we'll be working on that as well, just trying to promote some sort of reimbursement for them for doing an extra service.
Oh, that sounds really good. Yeah, I can see that dentists and dental systems would feel that way. One other question I have is tongue and taste impairment more common as we age? I know you talked about it being prevalent more in persons with diabetes and the preference for sugary drinks and foods and things like that. Is that degradation, is that a common aging issue too?
It is. Yeah, the little patella on your tongue, the little bumpies on your tongue are your low taste buds, and those just smooth out over time and get kind of worn down, just like your teeth. You'll notice older people will have like wear effects on their teeth, but things just kind of wear down, and your tongue does the same thing. So then older people just do not taste things like younger people do. So they tend to try to eat more sweets and eat more things that have more of a flavor so that they can get some taste out of that. But that's why older people like to you go to the nursing homes and they're all got peppermint and mints all over the place.
Yeah, that is interesting. Yeah, I had a patient that when we did a diabetes self-management education course at a physician office, he had lost his sense of taste because of a self-head injury. And he talked about and shared with the group how difficult it was to enjoy food because all he could base, now he had a pretty significant taste, I mean, it was completely gone. He could only enjoy food by remembering what it tasted like. Right, and how difficult it was to maintain a proper diet. He was a person with diabetes too, and how difficult it was to maintain a diet with that impairment.
Right, and all these things that we take for granted, healthy teeth and healthy tongue and healthy tissue, when there's someone who is immunocompromised, someone with diabetes or an elderly person, it just really changes their life. Mm-hmm. And that's why I always promote, your mouth is extremely important to your total body. You need your mouth to eat and chew and talk and socialize. And people just take teeth and mouth for granted a lot of the time.
Continue. Do we have any questions from the audience?
We do not much.
Okay.
That's for us today and for making the slides available. Again, anyone who would like a copy of the slides can contact me at mloush@mpro.org. And I want to, again, thank you so much, Susan, for your generosity, for doing the webinar for us, and for sharing your information with us. And thank you to all who participated today. And those of you that have not taken the evaluation, if you could do that before you sign off, we greatly appreciate that. And thank you so much to Tina and the WebEx operator for helping us today, and for all of you for attending our Learning in Action Network event. I hope you all have a great afternoon.
Thank you.
I'd also like to say thank you, ladies and gentlemen, for joining me. Disconnect and have a great day.
Thank you.